Welcome to the Evolved Caveman, where men learn to be successful and happy with your host, Dr. John Schinnerer, as he shares the most impactful ideas and practices for you to get the most from your relationships, your work, and from your life. Now here's Dr. John.
Hey everybody, this is Dr. John with the latest episode of the Evolved Caveman, and I am thrilled to have with me today from Australia, Jules Willcocks. And let me give you a little bit of Jules' background. Dr. Jules Willcocks is an emergency physician practicing at Gosford Hospital, just north of Sydney in Australia. He was the director of emergency medicine training for 5 years and is now the director of pre-vocational education and training, responsible for the supervision, well-being, and education of over 200 junior doctors. His interest in mentoring led him to train as an executive coach, and he's run multiple workshops at medical conferences on developing and using coaching skills in medicine. Much of his current role involves supporting junior doctors in the early stages of their careers, and as a result, he's developed an interest in wellness, emotional intelligence, and happiness. He feels that it is crucial to cultivate and develop these to have a long and successful career in medicine. His side interests, as kind of a Renaissance man, include professional poker. Through this, he developed an interest in psychology and performance under pressure, and has found many similarities between poker, medicine, and investing. He is a founding director of Twice the Doctor, a charity aimed at making it easy for doctors in Australia to make a difference in third world countries, which so far has raised over $650,000. Jules, thanks so much for joining us. How are you doing today?
I'm great. Thanks, John. Thanks for having me on.
Absolutely. So tell me, one of the positive psychology exercises is tell a story of you at your very best, which basically says, what's an area or a period in your life where you struggled and then overcame that struggle or that difficulty?
Probably one of the most important for me was when I was coming towards the end of my training. So we had to do an exit exam. It's about 1,000 hours of work, probably, roughly, which is in terms of study, which you have to do whilst you're working, full time and everything as well. And I'd sort of teed up mine to sit. It happens twice a year, and I'd teed it up to sit it at this particular time. My wife was pregnant at the time with our second child, so we had an almost 2-year-old, and she became a bit unwell with the pregnancy, and so I couldn't really work that much. I had to help look after the 2-year-old. She was confined to bed quite a bit. And so that really threw a spanner in the works. And that 1,000 hours, people say it's usually sort of 6 months to a year's worth of preparation for that exam. And my second son was born on the 27th of April, and the exam was in August. And I had to make a decision as to what I was going to do. And so I just in between the sleepless nights, I discussed it with my wife, say, well, what should I do? Should I try and sit it? Hadn't done much work for it because I've been busy looking after a 2-year-old. And as you know, it's pretty hard to do anything useful when you're looking after a 2-year-old. And we spoke about it, and, we had parents coming out to help. We were living in New Zealand at the time. And so I made a decision to do it. And I spoke to my director of training at the time and said, do you think I can do it in August? And she said, well, you're going to have to work bloody hard. So I just made a decision, okay, I'm going to do this. And so I went in and worked and studied 12 to 14 hours a day for the 3 months or so. And I passed that part of the exam. And then I got onto the clinical aspect. I thought, if I get to this point, they are not failing me. And it just became the be all. And it was a tough time. But it was a good time, and I passed, and the rest of my career has gone on really well. But it was it was one of those sort of almost defining moments of am I going to go this way or am I going to go that way, and delay it. And in retrospect, obviously, it was the right decision. But
yeah, it's a great story. I remember when my kids were young, one of the things I learned was to hold on to my agenda for the day very loosely. Because if I was going to watch kids, like some days I just had to throw everything out the window, which is hard to do if you're really goal-oriented, task-driven, and you're like, okay, I got to get these 6 things done today. You get really irritated if the kids have needs and they get in the way. So it's much easier to just go, well, I may get it done, I may not.
Yeah, and I think that's a really important thing when you're trying to juggle work and life and family life and so forth, in that, your job as a father is a really important job. And when you're doing that job, there really probably shouldn't be anything that's more important than that. Mm-hmm. So if you're trying to multitask things, and I've also tried now to earmark times with the kids and times, I need to get stuff done, and structure my life so that I do my other aspects of my work, which aren't, actual clinical on the floor stuff. Try and do that not when the kids are around, because at that point, the focus should be on them. And to be able to devote your attention so you can be present in the moment. Those moments don't, as you know, they don't last. They get older and they change. And, I was looking at some photos the other day of the kids when they were, 2, 3 and everything, and, all cute and everything. And now one of them's going to be a teenager soon. And those moments have never come back. So I think it's really important to try and do that, because if you start trying to do other stuff, then you start getting irritated. So you're not actually achieving anything. And you're destroying that relationship, and you're not really acting as a good role model to the kids. So it requires a different mindset and a shift in focus and priorities and things to be able to do both well, I think.
Yeah, I'm always talking to my male clients about having the ability to shift gears, whether that's shifting conversational styles, shifting emotional styles, shifting managerial styles. But I think that a lot of us get stuck in one gear and we're not even aware of other gears. And so I think having that ability to shift gears is huge. Yeah, and I think that awareness, listening to those emotions is really key. Listening to that feeling, like if you can, because it's hard to, and it's always different for different people. But those emotions are data sets, and they're trying to tell you something. So if you're feeling irritated, it doesn't matter what's irritating you, because it's going to differ for, all different people, different listeners. Mm-hmm. But if they can just pick up on the fact, hey, I'm feeling irritated now, and clock that and go, okay, so I'm trying to tell myself something here. What is it? What am I trying to tell myself? And then you can start to manage. If you don't have that awareness, if you don't have that emotional intelligence to go, hang on a minute, something's going. What am I doing here? Then you can start to manage it. Otherwise, you just get trapped in this loop of emotional reactivity, right? And you're just responding. And you're not being proactive, and you're not being mindful, and all those sorts of things. And so, I make the distinction about reacting with emotion versus responding with thoughtfulness and mindfulness. Yeah. So responding has a third of a second or a second in between the emotion and how you respond. There's a distance.
There's a cognitive distance in there, and I think if you can put together any aspects of sort of any of the behavioral psychology, any of those processes that people can use to give yourself that cognitive space. And it doesn't matter what it is. I teach this to my juniors at work. So for instance, if they're feeling stressed, because you don't make good decisions when you're stressed. Mm-hmm. Okay. It's that whole thing of, your prefrontal cortex, which is where all your higher functions are. And then your limbic brain, which is the reptilian or your caveman brain, which is designed to respond to threats. And as soon as that kicks in, the two things don't run at the same time. So you cannot think logically and access those higher functions. So you are then running on what's hardwired in. Now, if you've been training, like we do in emergency medicine. And so you're training in those resus situations so that is hardwired in. Then you can run on those programs. But if it's not hardwired in, you can't access it. And so to be able to give yourself some cognitive space when you realize you're feeling stressed or something like that, using some self-distancing, whatever it is you use is really important to be able to take you out of that emotional loop, because if your amygdala is firing up, you're back to that caveman reacting to the threat instinctively.
Right, you're stuck in fight, flight, freeze.
Yeah, and your brain, and we have multiple programs that are triggered often from years ago, which, when you're a child, there's lots of things. You maybe not even know that you're running these programs, but as soon as they start running, you don't have a control over it unless you can step yourself back. And so it's really important to try and do that no matter what the cause is, because the threat nowadays is often not a threat to survival. It's something on society, but your brain can't tell any different. Your body certainly can't tell that from the terms of what's happening to the hormones and things. So if you're constantly running on stress and anger, it's not healthy.
Right. That stress response is intended to go on, off, on, off, on, off. And most of the people that I work with are really good at turning it on, and they just keep it on.
And I think a lot of people, and we see with them, there's huge amounts of burnout and things in our profession. It's the same in the States from the figures that I've been reading about the States. And yeah, people are on and on and on and on, and they don't have the time to turn it off. And it exactly.
An MD here recently, and he's working 20 hours a day, getting 4 hours of sleep. And I'm like, you have to stop. Like, you can't continue at that pace.
So, yeah, I mean, I do a thing with my juniors and, look, we're all pretty much type A, competitive, high achieving type stuff. And so I've been doing a thing with my juniors and taking it into the medical schools now as well to say, how to be a well doctor. But the concept is, and this would be relevant for your guys as well, is that if you want to look after somebody to the best of your ability, then you have to be well. You cannot function at a really high level for a period of time if you yourself are not well. And we look at that, would you think of a high performance sports person or, a hedge fund guy, things like that, running on 4 hours sleep and expecting to make good decisions? We know that you don't. If you're tired, one of the first things that goes is your ability to accurately assess risk. Mm-hmm. So look at the airline industry. They're huge on all of that side of things.
One of the things I've been talking to clients about is the idea of self-care has got to be number one. And I think most of us are raised with the idea that we need to take care of everyone else. And, because it's selfish to take care of myself, right? But the problem is that when you do that, your bucket of positive emotions gets tapped out and emptied, and you've got no resource to share with others. You've got nothing to support others with.
Absolutely. And so, I try and tap into the whole competitive type A-ness of doctors by saying, if you want to be the best doctor that you can be, then you need to do this. Otherwise, you won't be as good a doctor as you can be, or you, in fact, might even be a shit doctor. Because if you start to go down that burnout thing and you lose your compassion and your empathy, we know that patients need that. You get much higher patient satisfaction scores if you score higher with emotional intelligence and with your empathy and with your compassion. Right. Your diagnostic accuracies are actually better because you end up getting better histories out of people if you have that rapport and that empathy. So it's really, really important. But we've got this weird thing where we look after everybody else, but we're not supposed to look after ourselves, Mm-hmm. And I think there is a problem in medicine sometimes where people say, "Oh, you need to go learn to meditate and do mindfulness," and but they don't actually try and fix the system. That's also wrong. I mean, you've got to get the organizations to try and fix the system, but we also need to look at ourselves and go, "Hey, this is really important. We should be agents for change on this because it's crucial to being a really good doctor and improving patient care."
One of the reasons why I was really excited to have you on the show is because you are an MD and because you are spreading the word about positive psychology and wellness, that to me is a very unusual combination. I see it in little bits here and there. Like I know Kaiser in the United States is working on teaching doctors compassion and self-compassion, but I think there's a lot of resistance from the MDs to it. And so I really like that you're training the junior doctors coming in and giving them those skills because we're not trained in that coming up.
No, we're not. It's interesting. I mean, in fact, if you look at some of the studies at medical school, that once you hit the wards, the traditional thing is, you spend 2 years, doing theory, and then you go onto the wards in year 3. And once you do that, your compassion levels start to drop. And that's pretty bad if we're teaching people that you should be less compassionate. And I think that a lot of the old style teaching, certainly when I came through, was you must be a little bit reserved. You can't let it affect you and things. But I think what we're realizing now is that empathy is actually really good if it's cognitive empathy. So if it's that I can see that you are suffering, or I can see that something is not right, or you're frustrated, whatever it is, name that emotion. And then I can start to address that. But the affective empathy of taking it on board and really feeling the pain and that's not so good because then that will burn you out over time. But the cognitive empathy of being able to then identify with somebody's pain or suffering or whatever it is, and then the compassion is the action that is a response to that. That's hugely important. I mean, that's really what we should be doing.
That's a skill to be developed, right? Because that's a pretty high level EQ skill of, let me differentiate between cognitive empathy and emotional empathy.
Yeah. No, it is. I think we don't teach it.
No.
So I think you've got to start with the basics, because before you get anybody even looking at other people's emotions, you've got to teach people to recognize their own.
Right.
And then manage their own.
I think we're at a disadvantage because we're socialized in the exact opposite way of don't feel, don't look at how you're feeling. And we're actually, I think many of us are mocked and humiliated for, feeling too much.
Yeah. And I think, again, this comes out of sort of share trading type, investing type stuff. If you try and bury those emotions, they come back and bite you. They're not going away, and they come back and bite you big time at some point. And so it's far better to recognize them, accept them, and then try and work out what's driving them and then dealing with that aspect. And I think it should be looked as a real strength. And I think you're seeing it in the corporate world a lot, that, emotional intelligence is something that they look for in leaders. It's not something to be shied away from. And we know that there's studies now that show that EQ is a better predictor of success in medicine than IQ. Mm-hmm. And which makes sense, because everybody in medicine has got to pass that IQ bar. Some might be way up here and some will be just there, but there's still not a massive difference between them. But if there are any of your listeners who are in medical field, or even, I'm sure people aren't not, you come across doctors who they may be really intelligent, really good at what they do, but they've got the personality of I don't know. Yeah.
Because part of what you need to do as a doctor is motivate people to change behavior. And if you've got no emotional empathy, or if you've got no emotional intelligence or empathy, it becomes really difficult to know how to motivate.
Oh, exactly. How do you do that? And if you just do that, talk the medicine. We do a lot of work on, communication strategies and things, and asking about patients' values and so forth. And really, to get into that sort of conversation, you've got to be able to do some emotional intelligent work, especially in end of life communication and that sort of thing, or that palliative care setting, or something like that. Those can be tricky situations. And if you're a retard emotionally, you're not going to have a good conversation there. Yeah. It's something that I have worked on and tried to develop. And I think that's the other important thing. We used to think that this was fixed, but we know now that with neuroplasticity and stuff, it's not fixed, and you can develop your emotional intelligence. And I've certainly found that in my own, in my own sort of growth of things. I mean, you talk to friends and family of mine, I'm incredibly unemotionally intelligent. It's all like me. And, I think I'm slowly getting better. Still got a long way to go.
It's a process that takes years. I mean, I remember back in my 20s, I'd been through the PhD program at Cal in psychology, and I woke up and I was like, wow, I'm still an emotional idiot. And that forced me to write the book and just kind of go into emotions and identifying them and how to work with them, partly because I wanted to learn about it.
Yeah. And I think that's the thing for me. If I want to teach it to the juniors, I have to learn about it and I have to role model it.
Right. So speaking of which, it's a nice segue. What are some of the issues that you're seeing with the junior doctors coming into the field these days? So bit type A and hypercritical. I think they often have a big inner critic voice. And we certainly do some work myself, a little program for them related to that. Self-efficacy can sometimes be an issue for them. Maybe thinking that they don't have that self-belief. It's different to self-confidence. You can be confident that you're going to fail at something. But the self-efficacy, the belief that you can cope with the task, it's a pretty scary transition when you come out of medical school and suddenly you're thrust onto the wards and having to deal with all this stuff and things. So that can be. I mean, look, don't get me wrong. They're a great bunch of people and it's incredibly rewarding working with them. And I love that aspect of my job. But there are things that crop up. I find that a lot of the issues when there's something going on, often it's a self-generated angst in how or they are having to deal with the fallout from somebody else's self-generated angst. So somebody else has behaved in a less than ideal way because they're dealing with something. Or they're not dealing with it and they don't realize it. Something like that.
Other things. I think sometimes some of their, and obviously they're learning, so they feel unconfident usually about their skills and development. They focus on developing these medical skills. And a lot of times I'm saying, no, don't worry about that. It'll take care of itself. Everyone's going to teach you that. You'll study anything, and you're kind of type A, so you're going to be like, I've got to do this, I've got to do that. And in fact, what you need to look at is yourself. A lot of the time you don't control a lot of stuff that's around you and things. So what you have to do is what can I actually focus on and control? I'm not responsible for how other people behave. I'm responsible about how I respond to their behaviors and things. So sometimes it's about saying, don't stress about all this other stuff and whether you're going to get a job, and you have to rush through and get your experience, focus on this, focus on that. What can you do now? So I like to try and get them to think about what their ideal behaviors are. What do they want to be like as a doctor? And that's one of the great things getting them at sort of day one is to say, if you think forward to your retirement and what kind of doctor do you want to be before they get tired, before they get cynical, before they get jaded, all that sort of stuff. And say, what kind of doctor do you want to be? What? And I don't mean like I want to be a great surgeon. What behaviors do you think? What do you want to be remembered for at the retirement? And write those behaviors down and stick them up somewhere where you can call yourself to account on a regular basis. And we have some interesting conversations about those. And obviously, there's a lot of things like compassion and caring and kind and things, which you'd hope would be in there. Things like somebody said they wanted to be approachable. And I said, okay, that's good. But what makes you approachable? There's something that underlies that. And then one of my other juniors came in and he'd sort of said, I want to have generosity of spirit. And I thought, that's what underlies approachable. Because it doesn't matter what the issue is that the person wants to approach you for. If you've got the generosity of spirit, they'll know that they can approach you for that. So we have some interesting conversations about that. And it's about trying to develop to define your values and keep an eye on those as you go forward. I think over the years, medicine's become a bit toxic in some behaviors in the organization. And it's be good to change that. And I think to do that, you need to role model it and you need to teach it. But if you don't know what you're aiming for, it's very hard to role model and teach it. So we talk about things like that. And we talk about some of the self-efficacy thing, working on the inner critic, and self-compassion is a huge one.
Yeah, let's go into that inner critic and the work by Kristin Neff and self-compassion. That's a huge one. I think all of us have that inner critic. Some of us, sure, it's louder and meaner than others, but my guess is that it's quite pronounced in MDs, that they're very driven, they're very hard on themselves.
Yep.
So where do you go with Kristin Neff's work in self-compassion?
Well, I've got a couple of copies of her book, and there's some people I just give it to you, so you just need to read this, or direct them to the website and say, look, go through this. But we talk about the importance of that. And there's one exercise I do with them is I get in a room and I say, okay, listen, I just want you to imagine that you've made some mistake. There's been some sort of adverse patient outcome or whatever it is, doesn't matter. Think of a mistake that you have made in the last few months. And I want you to write down the sort of things that you say to yourself. And then we collect them all in and we start reading them out. Now, you're so stupid. Oh my God, you'll never be a surgeon. You don't deserve to be a doctor. You're such an idiot. Da, 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 da. And then we say, okay, now I want you to think your best friends made a mistake, similar one to what you did. I want you to write down what you say to them. Oh, don't worry, everyone makes mistakes. It'll be okay. You couldn't have known this. And it's completely different. Mm-hmm. As a sort of snapshot across the whole thing. You've got one camp and then you've got the other camp. And I think that's sometimes quite eye-opening for people. People sometimes don't realize that voice is there. And that voice is there for a reason. It stops us doing stupid stuff. But when it gets out of control, it's not helpful. And so we do a lot of work on that.
Pardon me for interrupting. I mean, in working with men, I find that a lot of men have pushback to the skill because it's so foreign to them that they fear losing motivation if they lose the inner critic. And one of the things that I reassure them of is, your inner critic is never going to go away.
Yeah.
I mean, that's almost impossible. And if it works for you, great. But here's another way to go about it that's kinder, gentler, and has been shown in research to be more powerful than self-esteem because it irons out the highs and lows in your mood and emotion.
Yeah.
And so the funny thing about it in an exercise I do is you get kind of similar to what you're doing, but then you ask, what was the intent? What was the motivation of the inner critic? What was he trying to get you to do? And it's like, oh, okay, well, he was trying to get me to lose weight. Okay, well, in the same situation, what's the motivation of the self-compassionate voice? Oh, he was trying to get me to lose weight too. Well, which feels better to you? And so it's just, again, it's that idea of being able to shift gears and use different tools mentally that serve you.
Well, the other one I've done with some people is like a 3 chairs exercise. You know, when you sit in one chair and then you say what you're feeling, then you sit in the other chair and you say what the inner critic is saying out loud. And then in the other chair, it's like, well, now what do I think of those? And sometimes even just saying it out loud, you suddenly go, whoa, really? And just that different perspective makes people go, yeah, that's insane. Yeah. So I think the inner critic has its place. Absolutely. Do you come back at them like over and over to reinforce self-compassion, just out of curiosity? Yeah, I mean, so one of the things we set up was this program, Talk It Out Tuesdays, which is when we have a meeting once a term where we get people to come in and talk about any mistakes that they may have made. Because if you don't make mistakes, you're not doing enough medicine. And anybody who says they haven't made any mistakes is lying. So we get them in because we want to normalize it. We want to learn from it. And we want them to be able to have these skills. And also it's a good way of picking up people who might be struggling a bit or having some distress. You know, there's a lot of tears that come out at that point because they think they're okay, but in fact they're still, just going around. Yeah. And we try and teach them that rumination is not healthy, but reflection with self-compassion is.
Because rumination, if you get locked in rumination, that's depression.
Well, you just go round and round and round. There's no out.
Right.
And there's no resolution to it. And so you just go round and round and round in this sort of negative spiral with this negative voice going, Whereas if you can reflect with a bit of that self-distancing and a bit of self-compassion, then you go, okay, well, and what can I learn from this? How can I make sure this doesn't happen again? And then so forth.
Yeah, I like the mantra of fail forward fast. But it's funny because, again, the way we're socialized is we don't want to make mistakes because mistakes are embarrassing and shameful. And so we do everything that we can to hide our mistakes and not make mistakes. So it takes some work to get past that conditioning.
Yes, absolutely. And look, I've heard other people on other podcasts and things saying that sometimes working with high functioning individuals, that acceptance, that ability to accept the thing is the hardest thing that people push back. If I, like you said earlier, if I do, I'm going to lose my motivation. This is what drives me. Mm-hmm. And if I don't have that fear of mistakes or failure, then I'm not going to be driven. And it's like, well, actually, that's not true, because you still have your own personal goals and values that you strive for excellence. I try to
shows that as we activate that self-compassionate, that inner voice of kindness, we don't lose a personal responsibility. We don't lose our goal achievement. We actually get better at it. And that's one of the big concerns of my clients is, wow, if I'm kind to myself, I'm not going to get anything done. I'll just be kind of like skipping through the fields and not caring about anything. It's like, no, that's not going to happen. Yeah. And research backs that up.
Yeah, exactly. And I think the other thing that I do, and it's tied in with this, is that, perfectionism, I think, is really damaging and dangerous. Perfection in medicine does not exist. It's a game of incomplete information, like poker, and you cannot play perfectly. You just can't do it. So to strive for perfection means you're always going to be disappointed. You're never going to get there. And so you're going to always feel that you're lacking. Whereas striving for excellence, absolutely, we're not aiming for mediocre here, but you can strive for excellence, and that allows you, that gives you that get out game. You know what? I've tried my absolute best, and something happened here, because a lot of times things happen that are no control of your own whatsoever. And I think sometimes we're very bad at judging the quality of our decisions because we often base them on the outcome rather than the information that was available at the time. In medicine, we have this thing when we do look at root cause analyses and morbidity and mortality meetings and so forth. If something goes wrong, there's always this thing, people call the retrospectoscope. So it's the most powerful thing in medicine because you look at all the details and go, well, you clearly should have done that. Well, I didn't have any of that information available to me at the time. So, how could I know? And it's a very hard thing to guard against sometimes, especially in your own head if something bad has happened. And so I think if you ask a lot of people what was the best decision they made last year, it'll be something that had a good outcome, but that may not have been the best decision that they made.
So are there, when we talked earlier, you talked about dealing with that imperfect information in the ER. Are there any other tips or tools that you use to do that? One of the things, let me give you a second to think. One of the things that always amazed me is, doctors in the ER, or I've seen, like EMTs at concerts, for example, someone goes into a seizure or passes out. They have very, very little information to go on. Like I'm thinking at a concert, like, I don't know, the Grateful Dead, but we don't even know what drugs are in that person's system. And there could be 3, 4, 5 different types of drugs in there.
Yeah. I mean, sometimes it doesn't matter because you're going to treat it the same anyway.
Okay.
So you can do that. I mean, a lot of what we do is pattern recognition. So, 90%, 95% of what I do probably is pattern recognition. I think the hard part is to work out when I need to go from system 1 thinking to system 2.
Tell me more about that.
The ED has been described as a natural laboratory of error, just from the way it's set up and the business. I mean, because the volume of people coming in is such that you can't do system 2 thinking because the whole place will grind to a halt.
And system 2 thinking is like intuition, correct?
So the system 2 is a slow thinking, when you're slowing down and you're logically going through this. Whereas, system 1, bang, heuristics. Bang. Okay. Yeah. Have I got that right way around?
I think
I got
that's
right.
right.
Yeah, I think so. Now you got me doubting myself.
Yeah.
But it's the whole Daniel Kahneman thing.
Okay.
You got your pattern recognition switching because there's so much information coming in. That's what we operate on nearly all day, every day. Most of us, we're just reacting to stuff through patterns. But every now and then you need to go, oh, hang on, I need to slow down. This is maybe not, because we fool ourselves a lot of the time. We make a lot of mistakes. So, a lot of what we do is that. And I think trying to work out when you need to access a bit more thought and slow down is really key, because those are the times when you're most likely to not do that as well. So being aware of some of your cognitive biases.
That you need to slow down and move to that system 2 thinking.
So there's that feeling of a little intuition. There's a little voice in your head when you're playing poker sometimes which says, fold. You should listen to that voice. That has cost me thousands, tens of thousands of dollars not listening to that voice. And it's cost, and I've saved myself tens of thousands because it's trying to get out through all of your cognitive biases. It's picking up on these little subtle clues and you'll need to be right. And, whatever else is going on at the table and things. And, maybe I'm down a bit. I want to get back. If I win this pot, I'll be back. All those sorts of things. It's fold. And you need to listen to it. And the same thing in medicine, I find there's a little voice every now and then that just starts going, something's not right here. You need to listen to that. It's a really powerful thing because it's trying to get out through all those pattern recognition things against all the volume of stuff that's going on.
Well, and it seems to get there that you've got to practice slowing down and tuning inward in order to be able to even hear that.
Yeah, and it goes back to what we were saying earlier about your emotions are data sets. Mm-hmm. And so if you can be aware that, because if you don't recognize it, then you're going to ignore it. And then you're just going to repeat patterns of behavior and repeat mistakes. And you see that all the time with people doing investing and trading and stuff, that they do the same mistake again and again and again. And, they blow up the account again at a certain point or whatever. And these patterns of behavior just come out and repeat. And so you actually need to be able to tune in and go, okay, hang on, what am I feeling? Oh, okay. So why am I feeling that? There's something going on. And just that pause, that putting that cognitive space in there, that self-distancing to go, what's going on? Do I need to relook at this? How can I change this around? There are certain techniques you can use in medicine when you're approaching a diagnosis to look at flipping it around. What if it isn't this? Or what if this one abnormality is the key thing and everything else is irrelevant? So there's ways that you can deal with that to try and get some differential diagnoses and change your mindset.
So let me ask you this. So to what extent does tuning into your physiology come into the equation? In other words, do you see a heart rate increase? Do you see muscle tension somewhere? Do you see shallow breathing? Do you see any sort of expression on the face? Does any of that kind of, or maybe it's stomach, like butterflies in the stomach or nausea?
I think it'll be different for different people, and I think it'll be maybe different in different situations. It may be, if you're in a, for some people being in a pediatric resuscitation, pretty stressful, so the heart rate might be going into that, and so there'll be some stress which will then come in, which may then predispose them to certain errors. Then there might be a day when it's just the volume coming in is horrendous, and you've got people who are getting frustrated and shouting at you and this and that, or you've had to do a takedown because you've got some drug affected, and so you've got stress coming from a slightly different way. But it's about or the department's completely on its ear and totally full, and you're just running around trying to get some flow moving and things, and still trying to make decisions and see what you can do. And so there'll be different stresses and different times that'll impact on you. But I think it's when you try and go and have that interaction with that patient that maybe you need to just go, okay, I'm going to pause for a second now. I'm going to just focus on this, whether you can put that space in there or not, or being aware that you might need to, because you are just really running on pattern recognition, bang, bang, making quick decisions, bang, 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 bang. Mm-hmm. And I know that's one of my cognitive biases that I, early diagnostic closures, that thing, it's this, bang, let's do this, and make that decision quickly, because that's what I'm being forced to do by the system that I'm working in, rather than saying, oh, okay, what's going on here?
How much do you think, with that, the quick decision making, how much of that do you think is an attempt to look like we know what we're doing, an attempt to not want to be embarrassed?
Yeah. So that's a really interesting one. And I think you see that a lot, especially with some, certainly in juniors and stuff, the conversation when you get talking to somebody, and you get that conversation, it kind of goes on, and they're just explaining again, and they're this way and that way, and they kind of, because rather than just going, hey, no, don't worry about it, and just, or not wanting to say that they don't really know. That's another big one. And you have to be comfortable with that. And often our patients aren't. They want an answer.
Right.
And so sometimes you have to couch it in different terms and say, look, I don't know what infection your child has, but I do know that it's not serious. Mm-hmm. So it doesn't matter which virus it is. It could be one of a million different viruses, but it's not important. It's going to settle down in a few days, and we're not concerned. So, I can't tell you exactly which one, and I'm not going to test for it because it's irrelevant and it's a waste of time and money, and and so forth. It's going to cause suffering to give. It doesn't change anything. They just need paracetamol, some fluids, and just chill out for a few days.
No, on that topic, pardon me for interrupting again. How does the accuracy of language that you use with patients enter into this? And the context of the question is that my dissertation advisor at UCSF had done some research into languaging being used between doctors and patients. And what she found was that, at least in the US, we don't understand probability words like almost, never, sometimes, often, and always. If you ask people to put a probability on those words, it's all over the map.
Oh yeah, and is that, are you talking about for patients or for doctors? Because I would say it's the same for doctors as well.
Probably, but in this instance, it was doctors explaining things to patients.
Yeah,
and the patients weren't understanding.
Yeah, well, I had a conversation with one of my juniors the other day. So we had, I was just scanning the board, and there was a young woman who'd come in with a headache, and I thought, so there's one condition where you can have a spontaneous bleed in the brain. It's pretty rare, but it's a really bad thing, or can be a really bad thing if it happens. And there's a thing called sentinel bleed. So a couple of weeks before, you may get a small bleed, so they get a really bad headache. And one of the characteristics we've all been taught at medical school is that the nature of the bleed is it's the worst headache you've ever had. Now, if you ask somebody in the ED, is this the worst headache you ever had? They say yes. It's like, of course it is. Why am I here?
I'm in the ER.
And so it's crucial to take a good history. And actually, despite all of our technological advances, the most important thing is taking a really good history. And to do that, you've got to have a really good rapport, and that emotional intelligence helps with that. So it goes back to that. But anyway, to go back to this guy. So I'd looked at this thing and I'd read the triage, and she had a history of migraines as well. So I figured, just play the odds here. She's young, she's female, she's got a history of migraine, she's got a headache, she's probably got a migraine. Mm-hmm. So I said to the guy, I said, okay, hey, so what's going on there? He goes, I'm going to do a CT scan. I said, please tell me you're not. I said, why are you doing a CT scan? Well, it's the worst headache ever. And, just want to make sure she hasn't got a subarachnoid. So I said, okay, well, I'll bet you $10 that CT scan won't show subarachnoid. And now they know that I'll do this all the time with them. And they don't usually take my bets because they usually lose. So he goes, no. I said, okay, look, I'll give you 10-1. And he's like, no. I said, okay, I'll give you 20-1. He goes, no. I said, well, what do you need? He goes, I need 100%. And I'm like, yeah, but the scan is only 96%. Mm-hmm. So you're doing a scan to reassure yourself about your own insecurities, and then you're going to accept that even though it doesn't actually match up to what you want. So are you going to go and do a lumbar puncture on this woman to look for the blood in the swelling? Oh, no. So now you're actually not following through on what you should be doing. So why is that? And he was like, oh, I hadn't really thought of it like that, And I went and talked to her, and, she'd woken up with a headache, and it was the worst headache. It was the worst migraine she'd ever had. And we just gave her some migraine treatment, and she was fine, and didn't need a CT scan. But the point was that, like you say, we are very bad at assessing probabilities. Mm-hmm. Very bad. I think as doctors and as, my knowledge is
as humans.
As humans, yeah. And I've also heard people say, in terms of consenting for procedures or something, if you have, say you're going for a spinal operation or whatever, and there's a 2% chance of paralysis. I've also heard people say, well, yeah, it may be 2% for you, but for me, it's 100% or nothing. Mm-hmm. So kind of it changes that, depending on the outcome and stuff. And we have to be cognizant of that. So, if I think there's a very small chance of something happening, but that outcome is potentially catastrophic, then I am going to give more weight to that diagnosis because it's more important than if I think there's a reasonably high chance of something, but it actually doesn't really matter. Right. So you have to be able to learn to judge those things as well. And I think, teaching people to use Bayesian theory a little bit is good. Mm-hmm. You have a hypothesis. And then as you bring in new information, you then reevaluate that hypothesis and see if it needs to change. That's really important. And I try and get my juniors to think in bets a bit as well now, or in percentages. Because I think seriously trying to put some real active cognitive effort into this is important.
Yeah.
If you wanted to make good decisions, you've got to actually look at how you make those decisions. So, for instance, if I might see somebody who's fallen over and hurt their wrist or kidneys, and I say, okay, so what do you think? Is it broken or not? And they'll go, I don't know. So, well, that's not a good way to learn. I don't know. Tick, I'll do an X-ray and then I'll work out if it's broken. So do you want to be doing, all of your tests should be there to confirm or refute your hypothesis of what it is that's going on. So do you think it's broken? Yes. Okay, so you're going to do an X-ray to look for the fracture. What percentage? And what percentage do you think it's broken? Oh, 100% or 90% or, whatever. And so there was one when they said, 80%. And so they did an X-ray. I went and see the kid. 100% this wrist was broken, swollen and slightly bent. But if they've done that, they can go, okay, well, I have 80%, and I look at that, and I've got all those things. Now, next time I do that, I can go, well, I had that, so maybe next time I'm going to pick 85, right, or 90, or the other way around. Last time I was 80%. And it wasn't broken. So maybe this time I'll go 70%. And so now you'll start to refine the decision-making process. And so you're learning from what you've done before. So that's a really useful thing to do.
Well, Jules, I really appreciate talking to you. I really appreciate your time. I unfortunately I have to wrap up because I've got to take my daughter to soccer practice, and then I'm going to see Mumford & Sons tonight in the city.
Oh, nice.
But thank you so much for joining me.
Oh, thank you.
I can't overstate how appreciative I am of the work that you're doing in the medical field. I think it's amazing work, and I'm very grateful.
No, thank you for having me on. It's been fantastic to have these chats, and maybe we can do some more in the future.
That would be fantastic.
Great.
Thank you for listening to the Evolved Caveman podcast. If you like what you've heard, support us by subscribing, leaving reviews, and sharing the podcast with friends and colleagues. For the latest, most powerful tools to connect with like-minded men, join the Facebook group at The Evolved Caveman. Follow Dr. John on Instagram at The Evolved Caveman, all one word, or join the email list by visiting guidetoself.com.